Hello, everybody. My name is Saye Khoo. I'm an infectious diseases pharmacologist in Liverpool, and I bring you a very warm welcome. It's a great honor to be invited to talk at your meeting. So, can I have the first slide, please? We're going to talk about HIV drug interactions today, and here are my declarations at the bottom of the slide. So today, in the time that we have, I'm going to talk about the problems that we have with drug interactions in 2020. And I've split these into three areas. One is around the area of aging, multimorbidity, and polypharmacy, something that's very much happening in your country as much as in my country. The second I'm going to talk about is an area that is often missed, which is drug interactions in someone who's acutely unwell. Usually this is a late presenting patient with a new diagnosis of HIV, but in 2020 this includes COVID-19 as well. And thirdly, I'm going to talk about all the DDIs that are still a problem after all these years. So let's start. I'm going to talk about pharmacology, drug disposition in people who are old. So you read a lot in the textbooks about the fact that actually people who are old have different PK, pharmacokinetics, different pharmacodynamics. And I want to check that today to see actually if the data actually support that, whether that's really true or whether that's not. So there are many reasons why older people may have different pharmacokinetics or PK, that they might have higher levels of drug in their blood. Most importantly, declining renal function with age. So as you get older, your renal function gets worse, and drugs that are cleared by the kidney, so tenofovir, FTC, 3TC, are going to have higher exposures. As you get older, you have changes in body weight and body composition, different amounts of fat, different amounts of water. You have changes in gastric pH, so that's going to affect rilpivirine, atazanavir. You have changes in protein binding, liver function, and so many other areas. So these are the theoretical reasons why drug concentrations may be higher. There are other reasons as well, which are pharmacodynamics. So these are the fact that older people are more sensitive, are less tolerant, and more sensitive to sedation, to confusion, to unsteadiness of gait. If you're frail, your sarcopenia, falls are more likely, and you can more likely to break bones if you've got osteoporosis. Older people are also more susceptible to changes in blood pressure and postural hypertension. So if you combine those two, then there are reasons to be worried about drug interactions in older people. First, you get high levels, but importantly, you get toxicity even at normal levels of drug. So the therapeutic window for the drugs is smaller. So if you look at the data for 3TC, FTC, and tenofovir, so three renally cleared drugs, you can see from the POPPY cohort, that's a cohort of older people in the UK, that when you split the drug levels up into the quintiles, which is in the horizontal axis, the highest drug levels for tenofovir, FT3, and 3TC happen in people with the greatest impairment of EGFR, so lowering of EGFR, okay? And abacavir, which is not renally cleared, there's no difference. So this supports the fact that actually kidney disease gives you higher levels of tenofovir, FTC, and 3TC. But there are plenty of old people with totally normal kidney function. So what is the PK like for them? Well, other than the effects of glomerular function, EGFR, and body mass index, actually there's not a lot of evidence that age itself gives you a different exposure to PIs, to NNRTIs, and to the other NRTIs that are not renally excreted. Okay, so there's not a lot of evidence that the differences are clinically meaningful, and there's certainly no evidence that you have to behave differently. In other words, that the differences, any differences, if they are there, are clinically actionable, because these drugs are so variable from people to people anyway. Okay, so people talked about compartments, about the effect of menopause, etc. It doesn't really people who are older don't really have an appreciable difference if their renal function is normal. It is important when we talk about injectables in the future, because elderly people have less muscle mass and sarcopenia, so injections may be a logistical difficulty. All right, what about pharmacodynamics? Now, here there's really good evidence that you're dealing with a much bigger problem. So we know that old people are more susceptible to confusion. So we have, in the geriatric literature, we look at something called the anticholinergic burden. So if you're taking a alpha blocker for your prostate, you're taking a bit of anti-Parkinson's drug, or you're taking SSRI for your depression, or an antipsychotic, then these things all add up the anticholinergic burden and make old people confused. Yeah. Okay. The same with sedation, and here is also true with blood pressure. So you can see here with amlodipine plasma levels at the same plasma concentrations of amlodipine, older people, which is the white triangles, have a lower blood, so they have a bigger blood pressure drop. So they're much more susceptible. And of course, if you're frail and you're a bit immobile, then you're more likely to have falls. And these are big issues in pharmacodynamics. Old people don't just have one multimorbidity, they have multiple morbidities, actually. And these are not randomly distributed. In other words, everyone's got an equal chance of getting this. They tend to cluster, and they cluster because there are common genetic factors. You've got genetic predisposition, like say diabetes. You've got common environmental factors, diet, gives you obesity and diabetes, and also common risk factors. Smoking gives you heart trouble, strokes, and chronic bronchitis. So because of the clustering, if you look in the HIV negative literature, you will see clusters. And if you look at HIV positive older people, and this is the poppy cohort again, you see exactly the same thing. And so here you see in the UK, patients over the age of 50 years, in the poppy cohort, there are 4 clusters. So in the red circle, there is the cardiac cluster, angina, MI, heart failure, and hypertension. And you have an overlapping cardiometabolic cluster, which is the orange, okay, where you've got hypertension again, but this time with diabetes and hyperlipidemia and TIAs and vitamin D deficiency. So you can do these principal components analysis, a statistical tool to detect these clusters. You've got cardiac cluster, you've got cardiometabolic cluster, and then in the blue circle, you've got a mental health cluster. So that's anxiety, sleeping problems, depression, and panic attacks. And also sometimes linked to this cluster is chronic pain. So you get people who have these clusters, okay? And then the 4th cluster here is not surprisingly for HIV, sexually transmitted diseases, hepatitis C, gonorrhea, HIV. Okay, so bear in mind these clusters of mental health, cardiac, and cardiometabolic. So what we did a few years ago in Liverpool was to do this. So we took all the people with a cardiovascular cluster, cardiac cluster, and we looked at all the drugs that they would have: heart failure drugs, hypertensive drugs, okay, drugs for MI, all right. And we looked at people in the cardiometabolic cluster. So we looked for amlodipine, calcium channel antagonists, beta blockers, metformin, and statins. Okay, those are the drugs that would be used in the metabolic cluster. Or we looked at a mental health cluster. So these would be SSRIs, benzodiazepines, zopiclone, all these things. Okay. Now, if you look at all those drugs that are in that cluster, all these co-medications used to treat the cluster, and you look at people who are taking a boosted regimen, so boosted darunavir, boosted atazanavir, or elbitergovir, you see that about 30 to 50% of patients will have a clinically significant drug interaction. That's to say, drug interaction is amber or red in the Liverpool database, okay? So nearly 1 in 2 patients will have a drug interaction that's significant. All right, now we don't use so much these regimens, we use modern regimens. What is the evidence like? And you can see from here that actually the modern regimens, so rilpivirine containing regimens, doravirine containing regimens, unboosted integrase inhibitors, okay, they're all very low. They're all very low compared to the past. So we are now dealing with much cleaner regimens. Notice it doesn't matter whether you use 2 or 3 drugs, Dovato and Trimac about the same, okay? So actually, there are other reasons for using 2 drug regimens, but less drug interactions is not one of them. Every modern regimen nowadays has a very low drug interaction profile. So you look at this and you say, well, look, drug interactions, no problem. What's the issue? It's a finished problem. This shows you the relative risk, okay? The relative risk of a drug interaction in 2020, all right, with the modern regimens. but what is the absolute risk? Okay, that's a really important question. And for that, you need to look at the prevalence of drug interactions. And here I've shown you about 30 studies over about 8-year period or a 10-year period. For a long time, looking at drug interactions. Actually, it's more than that. It's about a 15-year period. And you can see the orange circles are European studies. The red circles are done in the USA. African studies are blue. The rest of the world is in purple. So you can see that the figure has not really dropped. You would expect with the last slide I showed you that the figures in 2020 would be right down less than 10%. And instead it ranges from about 10% to about 50%, 40, 50% in the last couple of years. So why is that? Well, we believe that there are two curves going up here. We are using cleaner regimens, so the relative risk is going down, but we have more older people. That's a second curve. So with more older people, with more multiple morbidities and more polypharmacy, and so the numbers of drug interactions are going up. And so that's why it hasn't really changed, and that's why the absolute risk hasn't changed. There are other interesting things you can get from this picture as well. So if you look at in 2020, okay, at the newer drug interactions, you've got you've got a number of observations. Okay, so first of all, the countries that use more integrase inhibitors, you look at France at the bottom, so 48% integrase use. Madrid, 51% integrase use. USA, 20%. Okay, Swiss, 41%. So if you use more integrases, your figures tend to be lower. And if you use less integrases, so Tanzania, 0%, Barcelona, 14%, UK, 27%, they tend to be higher. Okay, and that makes sense. Second thing that you'll notice also is the same drugs. For the last 10 years, it's been the same drugs. Steroids, all the time. Okay, inhaled steroids, topical steroids, okay, injectable steroids. Quetiapine, again and again and again it appears. PPIs, again and again and again it appears. Okay, so it's the same drugs coming up again and again. Amlodipine, okay, and maybe one of the newer drugs that's coming on increasingly are DOACs, and we'll talk about that later. So, where are we with drug interactions? So I've introduced to you the concept that actually we still got the same problem, but we also have another problem on the other side of the coin, that people are now aware of drug interactions, and they are too frightened of drug interactions that they don't manage the condition properly. So there's a study from Italy showing that people with depression don't have high enough levels because people are frightened to give the proper treatment for depression. The same study from Chelsea and Westminster in London showing that people on a boosted protease inhibitor using statins have less good control of cholesterol and hyperlipidemia because people are frightened to raise the dose. So you use 10 milligrams of amlodipine, never use more. Statins, you only use pravastatin, which is not one of the strongest statins and not ideal if you've got high risk plaque, and you don't use atorvastatin, for example, okay, or some of the other more anti-inflammatory statins for much more aggressive treatment. So we have two sides, and I'll show you the illustration here in this very quick case history. So we've got HIV positive patient of mine who has NNRTI resistance, given Truvada darunavir, and the HIV doctor is very happy because he's durably suppressed despite resistance for 10 years. But in spite of that, his kidney function is going down and down and down. Started at 70, is now about 30. He's got multiple strokes. He's got atrial fibrillation. He's getting dabigatran. He's got diabetes, which is badly controlled. He's got blood pressure, which is badly controlled, and he's got lipids, which is badly controlled. Okay, so this patient is, I would say to you that this is a man who is dying, and yet his HIV doctor is happy because he's virologically suppressed. Okay, he's dying because his kidney function is going down. He's got strokes, atrial fibrillation. His cholesterol, which is the second graph you see, is high. The green is the normal range. It's never been normal in 10 years. His glucose, HbA1c, is abnormal, never been normal in 6 years. Okay, so this is a real problem. This is a real problem. He's not going to die of HIV, but these other things are going to kill him because he's not being managed well. So I want to challenge doctors now to look at these things. Okay, so yes, you can switch from tenofovir TDF to TAF, because you want to avoid abacavir. That will sort out be slightly better for the kidneys, but the blood pressure is still not controlled, and the glucose is still not controlled. So this is still a problem for his kidneys. Okay, be aware that with DOACs, particularly dabigatran, ritonavir and cobicistat are different. So cobicistat is a pure inhibitor, and ritonavir is an inhibitor and an inducer. So it'll push it up a little bit, push it down a little bit. Dabigatran won't change that much. Cobicistat completely inhibits. Dabigatran goes right through the roof. If you switch from ritonavir to cobicistat with darunavir, your dabigatran levels will go over, and you're very high risk of bleeding. So be very careful. And there's data in the Liverpool website for that. Okay. So nowadays we would use unboosted integrators, and I think all the guidelines, including in your country, are migrating to that view. Here's another story of a woman, an African patient of mine who's obese. Her BMI is 48. Type 2 diabetes on Truvada dolutegravir, develops TB meningitis in December 2019. And then in May this year, 3 months into TB therapies, fever, breathlessness, hypoxia, abnormal chest X-ray. You can see a very large heart here, interstitial shadowing. The CT scan at the bottom shows a huge BMI. You can see the huge amount of subcutaneous fat in that scan, but also interstitial lung disease and cardiomegaly. Okay, so of course there is a differential diagnosis in someone like this, but we're talking about 2020. We're talking about May. There's only one diagnosis you can make at this time. Where the D dimers are really high, and of course the SARS-CoV swab is positive. All right. And the patient's on a lot of drugs. She's on rifampicin, isoniazid, pyrazinamide, ethambutol, pyridoxine, which are TB therapy. She's on tenofovir, FTC, and double-dose dolutegravir because of rifampicin. And we need to add dexamethasone and remdesivir. Is there an interaction with rifampicin? And the answer is yes, there's a major interaction, particularly with dexamethasone. So you're giving low-dose dexamethasone. Rifampicin is such a potent inducer, it will wipe out that dexamethasone. Bear in mind, dexamethasone is really life-saving here, much more important than remdesivir. You've seen the data from the Solidarity study. And so we know from recovery that dexamethasone is really important. And there's a lot of headroom. You can go up. So I would always, in this situation, double the dexamethasone. Remdesivir is also cleared by 3A4, and rifampicin will lower levels of remdesivir, but you can't do anything about it. If you can get hold of remdesivir, you can't change the dose, okay? And it's so expensive as well. And there's actually now accumulating data that you don't need to change the dose of remdesivir. You can still give it with rifampicin. We can stop the rifampicin, but it takes 10 days for the rifampicin induction effect to wear off. And by then, you'll have finished your remdesivir and you'll have finished your dexamethasone. So you've got to manage this even with rifampicin around. So what would you do? The answer is quite simple. You would double up the dose of dexamethasone, at least, if not more, 6 milligrams BID, and then just start the remdesivir. You can stop the rifampicin, but it's not going to change the drug interaction in the meantime, maybe just a little bit, okay? And if you're stuck for facts, we have a COVID drug interaction website, which we have here to give you advice. So it's covid19druginteractions.org. All right. So I'm going to finish now with just a summary of the drug interactions in multimorbidity and acutely sick patients. So in these groups of patients, very vulnerable patients, DDIs are less likely to be recognized, okay? All right. Because there are different teams involved, cardiologists, ITU, renal doctors, chest doctors, and they're less familiar with our drugs, and we are less familiar with their drugs. And the medication recording is not always brilliant, okay? People don't write what they give. So I had a patient on dolutegravir, rilpivirine, and 3TC with renal failure who was given a calcium by the renal dietitian, so that compromised the dolutegravir, was given sodium bicarbonate by the renal doctor, so that compromised rilpivirine, and so that he developed a M184V because he just had 3TC monotherapy. So be very careful about that. I think a lot of acute doctors who are with very sick patients don't think that DDIs are important. And then they're more likely to cause harm. So in a healthy patient, your drug levels may go up 20%. If you've got liver failure or renal failure, they may go up to 100%, okay? And then you and then you get harm. And they think, and it's easy to attribute the harm to say that, oh, it's the disease, they're so sick. Of course, they had ventricular tachycardia. Nobody noticed all this ritonavir boosting QT, boosting the levels of a drug that causes QT prolongation, like quetiapine, for example. Okay, and these are harder to manage. You can't avoid certain important drugs like the antiarrhythmics for people who are quite sick. What about people with swallowing difficulties? NG2, can you crush tablets? And we know that Simtuza, TAF, FTC, and darunavir cobicistat, you can crush, all right, and that works very well. Dolutegravir, Triamec, you can crush also, and you can mix with NG feeds. People are worried about the fact that there might be metals. In fact, your dolutegravir absorption is actually better with NG feeds because of all the fat, all the lipids in it. So you can safely do that, okay? You can stop HIV drugs, and you can pick up the pieces. We have such good drugs now. You can rescue them afterwards, as long as you get them over that life-threatening illness, COVID or intensive care, whatever. Okay, except if you're giving injectable CAB and rilpivirine, in which case you can't stop that, and you've got to manage the tail. So you're on CAB and rilpivirine injectables, you develop TB and you need rifampicin, or you develop renal liver failure. You're going to have to manage the tail for that. And then, of course, there are many mistakes that people make over and over again. I've given you some examples, people not taking a full medical history. We're used to rifampicin drug interactions in TB treatment, but when we give rifampicin for staphylococcal infections, people very often forget that there are drug interactions. Okay, we don't stop drugs that are no longer necessary or in acute illness. All right, I've given you an example of divalent cations and renal supplements with integrases, PPI use and antacid use, okay? Many examples of these things, okay? So I'm going to finish now, and I hope that some of you at least will have used the Liverpool Checker. I've got excellent news if you have, because for those of you who use it and don't use, we have a fantastic partnership with Pedro Khan, with all the colleagues at Fundación USPED, and with our Brazilian colleagues as well, Mara Schechter, and we are hoping to launch next year a version of the website in Spanish and in Portuguese, which I hope will be useful for you. If you go to the UK site, we'll see many resources that we have, and these are food requirements or patients with swallowing difficulties, unconscious patients, treatment for gender-affirming therapies. I'll give you an example. So we're seeing more and more people getting hormonal treatment. What are the drug interactions? You will find this data chart that I've shown you on the website, okay? So I'm going to finish now, and thank you very much for listening. And I want to acknowledge all the help that we've had from our colleagues in Brazil, in Argentina, and also our colleagues in the Liverpool website. Thank you very much.